Okay, yeah, good. Well, good afternoon, everyone, and welcome to this talk. I've given a couple of talks before about um, uh, pediatric cardiology. Particularly, there's a talk on cyanotic heart disease, acyanotic heart disease, and variations of those. So you can look at those. They're more about the structural anomalies that children can have. But today, I just wanted to focus on the diagnosis and management of heart failure in children. A little bit different. Not all children who've got congenital heart disease are in heart failure, and not all children in heart failure have congenital heart disease. So there'll be more a discussion about heart failure overall, and how it can be recognised, how you can understand the differential diagnosis of it, and how it can be managed. Right. I want to start with something I've talked about before, which is trying to understand all the different causes of heart failure in children. And I think it's useful, I find, to have an anatomical understanding of the different causes of heart failure. And if you think about all the different parts of the heart, then there can be pathology involving all the different parts of the heart. And so, to start with, given it's the most probably the most common type of cause of heart failure, then structural congenital heart disease, which we always think about. We always think that a child might have structural congenital heart disease. That is a morphologically abnormal heart. And again, going back to the lectures I've given before about cyanotic heart disease and acyanotic heart disease, just look at those in terms of the an understanding of the different types of congenital heart disease. But the main thing to understand is what causes heart failure. Now, as I said, not all children who've got structural congenital heart disease go into heart failure. Some just present with cyanosis, some present with other things, but some do present with heart failure, and they're usually children that have large left to right shunts. Sometimes children who've got left ventricular outflow tract obstruction present in heart failure, but also sometimes they present in shock rather than in congestive heart failure. We'll talk about the differences shortly, but the biggest causes, of course, are large left to right shunts, and the largest causes of those large left to right shunts are ventricular septal defects largely, and also less atrioventricular septal defects, and occasionally a very large atrial septal defect, and in neonates and occasionally in infants, large patent ductus arteriosus. So if you think about those things, particularly PDAs and VSDs, being a little bit analogous, they're all large left to right shunts. And the left ventricular outflow tract obstruction conditions are things like aortic stenosis or hypoplastic left heart or coarctation of the aorta, and they also can present in heart failure or in cardiogenic shock. Then, so that again, taking an anatomical approach to the understanding of the causes of heart failure in children, then next are the valves, and valves can be abnormal either because of acquired or congenital heart disease. And of course, you can have congenital aortic stenosis. I've already mentioned that. But more commonly, we see children who've got valvular abnormalities related to acquired heart disease, particularly rheumatic heart disease. I'll talk a bit more about that later. And then there's the heart muscle. So we've got the structure, the morphological structure of the heart. We've got the heart valves, and then we've got the heart muscle. And again, there are some congenital and acquired conditions that can affect the heart muscle. And the most common condition is myocarditis, which is usually a viral etiology of viral inflammation of the heart. And this can occur with influenza, it can occur with Coxsackie viruses, enteroviruses that can affect the muscle of the heart, just the same as you can get inflammation anywhere, whether it's in the lungs or the liver or the muscles with viruses. Then you can get myocarditis, myocardial inflammation that leads to myocardial impairment. As I said, there's congenital and acquired forms of heart muscle problems, and the congenital forms are cardiomyopathies. Now, not all not all congenital forms of cardiomyopathy presents at the time of birth. In fact, most of them don't. Most of them present somewhat later, in later infancy, in early childhood, sometimes even in older children, in school-age children. Usually, it's in later infancy, or when children are 1 to 3 or 4 years of age, they'll present with cardiomyopathy. They can present at birth in early infancy as well if it's very severe, but equally they can present a bit later. And then so we thought about the valves, the muscles, the morphological structure of the heart, and then there's the cardiac conduction system, and and there are a variety of different arrhythmias that can cause heart failure in children. And the most common one is supraventricular tachycardia, which we'll talk a bit more about. There are other ones too. Some children with some problems can go into atrial fibrillation. Others can get ventricular tachycardia, but SVT is the most common one, most common arrhythmia. But that can put a child into heart failure. Then there's if again an anatomical understanding of the causes of heart failure. Then there's pericardial disease, and we have to just think about a child who's got a pericardial effusion for whatever reason. It could be TB, it could be staph pericardial effusion, and that can lead to tamponade and put the child into heart failure. And then, of course, there's a more, rather than an effusion or in conjunction with an effusion, there are some children that have constrictive pericarditis, which just means their pericardium is very constricted, it's fibrosed, it doesn't allow the heart to relax in diastole and therefore fill. And what usually happens is the heart can contract okay, but it can't relax and fill because there's a very constricted pericardium surrounding the heart. And that, of course, occurs in children who've got tuberculosis, who have what's often called bread and butter pericarditis, or really inflammation and fibrous thickening of the pericardium. And then there's some children that have heart failure secondary to lung disease, and you'll recognize in adults who have emphysema, severe emphysema, or chronic airways disease, and they develop what's called cor pulmonale, which is just right heart failure in response to lung disease. And those and there's an analogous situation in children. That is, children who've got forms of chronic lung disease can develop cor pulmonale. It's the same pathophysiology. And then there are some children that have pulmonary vascular disease that leads to right heart failure, and that can either be because of uh, pulmonary hypertension because of chronic lung disease. That can lead to a fibrotic inflammatory change that leads to changes in the pulmonary vasculature that lead to pulmonary hypertension that leads to right heart failure. Or they may be born with a congenital form of pulmonary vascular disease that progresses as they grow. And then there's the last anatomical, if you like, cause of heart failure, which is high output cardiac failure. And that's a less common condition, but there are some relatively common causes of that, including severe anemia. Now, most children with severe anemia aren't in severe heart failure, but many of them are. And if the hemoglobin is less than about 6, then often 6 grams per deciliter, then often children have some degree of myocardial impairment. They have increased intravascular volume, and also because they have anemia, then they have a reduced oxygen delivery to the myocardium, so they get relative myocardial ischemia because of the reduced oxygen delivery, because of the low hemoglobin, because the low hemoglobin is not carrying enough oxygen. And so that the combination of those two things, one, fluid overload, which occurs in severe anemia because when you have a low hemoglobin, the body tries to retain more fluid to maintain the cardiac output, and the low oxygen delivery that occurs to tissues that occurs with severe anemia can lead to high output cardiac failure. When the hemoglobin is low, the heart has to do more work, so you have a hyperdynamic circulation. There's a similar condition in thiamine deficiency, which we don't recognize very often, but it probably occurs more often than we do recognize. And those children also have high output cardiac failure. They often also have anemia, but it's due to thiamine deficiency. And many children with severe malnutrition who have heart failure from anemia would also benefit from receiving thiamine. And then there's a rare types of conditions where they have a high output cardiac failure because of large AV malformations. And we see a lot of children who have vascular malformations anywhere in the body, but if they have a large one where there's a arteriovenous malformation, then what that does is set up a very large shunt, and so the heart has to work even harder to pump enough blood around the body. That's a rare cause, but the main message of this is that try to take an anatomical approach to the understanding of all the different types of heart failure. The symptoms you'll be very familiar with, but there are some symptoms of heart failure that I think are probably not as well appreciated, and we often miss them. And many of them are age dependent. And we get used to thinking, well, the features of heart failure are tachycardia and hepatomegaly and tachypnea and chest crackles, but there are some other things as well. And some of these features, as I say, are age dependent, and some of them are rather characteristic of the underlying cause of heart failure. So, sweating or difficulty with feeding typically occurs in the young infant who's got a large ventricular septal defect, but it can occur in any form of heart failure, whether it's myocarditis or a congenital cardiomyopathy. But often these infants have difficulty feeding. They'll feed for a while and then they'll have to come off the breast, or they won't be able to take large volumes of feed. In older children, they often have anorexia or abdominal pain. And they have abdominal pain because they have relative gut ischemia. It's similar to if you've got what I said for anemia, where you've got relative lack of oxygen delivery to the heart. When a child's got heart failure from whatever reason, then the splanchnic circulation becomes more vasoconstricted, and you have reduced blood supply to the bowel. And typically, when a patient with heart failure of a moderate or severe degree tries to eat, then they get a lot of abdominal pain, and that's an important feature of relative gut ischemia. They often have older children have reduced exercise tolerance, and they also have somnolence, because you can imagine the heart's not pumping blood very well, so they're more lethargic, they're more somnolent. Of course, tachycardia and tachypnea, they're invariably so, and in some children they can identify that they've got palpitations, and that's because they've got tachycardia or they've got an arrhythmia. So I think it's good to just understand a little bit more about the wider symptoms of heart failure, so we can be detecting it. And especially, I think we recognise heart failure reasonably well in infants and young children, but in adolescents, it's pretty important to understand these other features, because it speaks to the severity of a child's heart failure. I've talked about this before, but when you're dividing heart failure, we often think of it as just heart failure, but sometimes you can distinguish the signs at least into those that are from predominantly right heart failure and those that are predominantly left heart failure. And many children have both biventricular failure, but the signs that are especially right heart failure are those where you've got congestion from the right ventricle, you've got high central venous pressures because the right ventricle can't pump adequately, and the end diastolic pressure in the right ventricle is high, and that leads to congestion in the venous circulation. So you have hepatomegaly and generalized edema, typically in the lower limbs, and you have a raised jugular venous pressure. Whereas left heart failure, you've got to think, well, what is being congested? Well, the lungs are congested in left heart failure because the veins that are draining into the left heart that will be prone to the high pressures from high left ventricular end diastolic pressure, if the heart's not functioning well, then that pressure gets transmitted to the pulmonary veins and therefore gets transmitted to the lungs, and you get tachypnea and often grunting and high um, pulmonary blood flow, depending on what the cause is, or at least congestion of fluid within the lungs because of that high back pressure on the lungs. And many children, of course, have signs of effusion. Not so common in young children, but more common in older children. And then there's the signs which we've sort of talked about um, in the teaching on shock, and so there's congestive heart failure, and then there's low output heart failure, and congestive heart failure where you've got back pressure either on the right side or the left side of the heart or both sides. And with low output heart failure, then the heart's not pumping adequately, so not pumping enough blood forward flow is inadequate, and so therefore all the things that are required in terms of oxygen delivery to tissues will be impaired. And so patients will have hypotension because the systolic function of the heart's not adequate. It's not pumping blood around the body. They'll often have weak pulses because of a response of vasoconstriction. They'll have often a narrow pulse pressure because of this vasoconstricted circulation. What I mean is that instead of, for example, a 1-year-old in heart failure having a normal blood pressure of like 90 on 50 with a pulse pressure of 40, they might have a blood pressure of 70 on 50 with a pulse pressure of 20 because of their peripheral circulation is vasoconstricted in an attempt to maintain their blood pressure, their mean blood pressure especially. So look for a narrow pulse pressure. It's quite a good sign of low output heart failure, a more advanced form of heart failure. Um, they often have cold peripheries because of vasoconstriction. They'll have oliguria or impaired renal function. That's very common in children with severe heart failure, low output heart failure. They've got inadequate blood flow to the kidneys, and some of the compensatory mechanisms of the body, the renin-angiotensin system leads to relative renal ischemia, and then they'll have an acute kidney injury secondary to severe heart failure. Very important to recognise in these patients. It's another reason why you don't want to give them a lot of fluid, because they won't handle the fluid load very well. Their kidneys have already started to become impaired. And I mentioned before anorexia or abdominal pain, especially on eating and somnolence. They're all features of low output heart failure. Um, and typically heart failure will go from congestive to low output heart failure if the underlying cause is not corrected, if the precipitating causes are not addressed. There's a classification system for heart failure in children. It's called the modified Ross classification for heart failure in children, and it really uses all those symptoms that I mentioned before, or a smaller number of those. And there's, just like in adults, there's class 1, class 2, class 3, and class 4 heart failure. And we do see a lot of children with class 3 or class 4 heart failure. And class 1 heart failure is where a child's got some underlying cause of potentially heart failure, but is largely asymptomatic and might have tachycardia, but is not otherwise symptomatic. Class 2 is where they've got mild tachypnea or sweating, but they don't have any other more concerning features. And older children have shortness of breath on exertion. Class 3 in infants, they've got more marked tachypnea with sweating on feeding, more severe sweating on feeding, and typically growth failure. You'll know that heart failure leads to failure to thrive typically, and in older children, then they often have more marked dyspnea on exertion. And then class 4 heart failure is, again, unfortunately, we see a lot of children like this that have all these features even at rest. So they have tachypnea, they have chest retractions, they have grunting and sweating, or very limited exercise tolerance, and they have these features even at rest. So just in terms of, it's useful to, when we see a child in heart failure, just think to yourself, what class of heart failure are they actually in? Right. What I wanted to do today is just go through three cases, and they illustrate the different forms of heart failure that I have discussed. And so the first case is a 4-month-old boy who presents with poor weight gain and several episodes where he's presented to hospital with wheezing, and he's been treated with for an acute respiratory infection for pneumonia on a couple of occasions. But over the last month or so, he's become more sweaty and had fast breathing on feeding, and is not failing to thrive just yet, but is really not feeding well. His mother says he's not feeding well. The second child is a 10 months old. This child was 12 months old, a boy who presented with a very high fever and severe pallor and tachycardia and a liver that was palpable 5 centimeters below the right costal margin. And he had other signs of heart failure, fine crackles and expiratory bronchi. So what I want you to try to do is to understand the differential diagnosis of each of these clinical scenarios, because much of this, what I'm talking about, is trying to recognize patterns, to understand the sort of pattern of the common presentation of each of the common forms of heart failure. And then the third case is a 12-year-old boy who had 3 days of high fever and difficulty breathing. His temperature was 39 degrees. He was quite tachycardic, 180 to 200, and he had an irregular pulse. His apex beat was prominent in the sixth left intercostal space in the mid-axillary line, and he had crepitations in both lung fields, and he had oxygen saturations that were a bit low on air, not very low, but a bit low. And he looked quite pale. Now, many of these children have similar characteristics. They've all got features of heart failure. But they're subtly different. They're different ages. They've got subtly different presentations. So I just wanted to go through each of these because I think they illustrate the commonest forms of heart failure. So this is the first child, 4-month-old boy who presented with four. This is his X-ray with poor weight gain and recurrent wheezing and sweating and fast breathing on feeding. And now, as I said, he on several occasions he'd been diagnosed with bronchiolitis and pneumonia and treated with antibiotics and oxygen for that, and he'd seemed to stabilize, but then he got worse again. He on on examination he had his pulse volume was adequate, but he had quite cool limbs and his capillary refill was 3 seconds. So you would say he's got some signs of congestive heart failure and some signs of low output heart failure with his cold limbs and prolonged capillary refill. On chest examination, he had crackles and wheezes. And again, it's often very hard to distinguish a bronchiolitis from this problem, the cause of this child's heart failure. But you can see from the X-ray, I mean, he has got some streaky opacities. He looks like actually he's got severe pulmonary congestion, and you can see that his heart is quite large. And if you see a child who's got recurrent wheezing and crackles and failing to thrive and sweating on feeding, they're real clues to might be going on. So you've seen his chest X-ray, and I think it's important to sort of think about the differential diagnosis here. So, of course, the most common cause of this is bronchiolitis, but I reckon every year you'll see of all the children with bronchiolitis, maybe 1 in 20 or 1 in 30 will actually have this other problem. The features are rather similar, but a bit different. And this boy's got a large ventricular septal defect, and there's a reason why these large VSDs become evident at around 4 to 6 months of age. If they're very large, 4 months. If they're a bit more moderate size, then around 6 months of age. They typically also have wheezes and crackles and hepatomegaly, and I'll talk about the other clinical features in a moment. But the reason they have wheeze, this is important, is that when you've got a high pulmonary blood flow going from left to right, then you have bronchial mucosal edema. The mucosa of the bronchi becomes swollen, and therefore the lumen of the bronchi is rather more narrowed. And it's just like if a patient's got bronchiolitis, where you've got a lot of secretions in the bronchi and bronchoconstriction, like in asthma, but bronchoconstriction, then you'll have wheeze, because wheeze is just simply airflow obstruction, and even a congested lungs causes airflow obstruction. Some of you might be familiar with, they used to use a term, especially in adult medicine, called cardiogenic asthma or cardiac asthma. And that was essentially older people who had pulmonary edema, acute pulmonary edema, and they would often have wheeze. It's simply because of the congestion in the bronchial mucosa. The third possibility in this case, you've got signs of heart failure, recurrent presentations with what was thought to be a lower respiratory infection, is a large patent ductus arteriosus, and you don't have to be a premature baby to have a PDA, and that can also cause wheezes and crackles. They have bounding pulses, and I seem to have lost the. That's all right. Okay. Typically, they have bounding pulses and a wide pulse pressure. So unlike other children, you can diagnose it based on the wide pulse pressure and the bounding pulses, and they have a continuous murmur, as we talked about before. This is the ECG of a child who's got a large same child, um, and the features that I want you to look at are the evidence of left ventricular hypertrophy. Remember, left ventricular leads are the ones. I'll just see if I can get my camera on again. The left ventricular leads are like V4, 5, and 6, and the right ventricular leads are V1. So you add up the R wave in V1, and you add up the S wave in V2. You add up the R wave in V5 and the S wave in V2. And if that's more than 35, which in this case it is, it's quite a very large, you can see the very large R waves, 5, 10, 15, 20, 25, over almost 30 millimeters on V5, and then SV2, 5, 10, 15, 20. So it's clear in this case of left ventricular hypertrophy or left ventricular strain, and you'll see that it often in large ventricular septal defects. I won't go through how to read an ECG. There's another talk on that, but just to know what the features are in large VSDs. The small VSDs can present with just an incidental murmur. Large ones present with congestive heart failure and all the features we talked about. And the clinical examination, usually there's a parasternal heave. That's because the left ventricle is hypertrophied and larger. The apex beat can be displaced, like you saw on that chest X-ray. There's often a pansystolic murmur that's best heard at the lower left sternal edge. And remember, I've talked about this before in terms of congenital heart disease, but if you move your stethoscope down below the xiphoid process, then the murmur will be adequately heard. Like that is in the upper abdomen, just underneath the xiphoid process of the sternum. You should still hear that loud pansystolic murmur of the ventricular septal defect. Remember, the differential diagnosis of that is mitral regurgitation, and then the murmur will be heard more in the left axillary region. The loudness of the murmur is not indicative of the defect size, so you can actually have a very large defect and not a very loud murmur, or you can have a loud murmur and that reflects a relatively smaller defect. Yeah, that's again, I've talked about ventricular septal defects in the lectures on congenital heart disease. That they produce left to right shunts, as I mentioned, and sometimes this is an important concept. Okay, it's an important concept that in a large left to right shunts, often the pulmonary blood flow relative to the systemic blood flow will be 1.5 or 2 to 1 or 3 to 1 in a very large shunt. And what that means is that sometimes more than normally, it should be 1 to 1. The amount of blood going around the pulmonary circulation should be exactly equal to the amount of blood going around the systemic circulation. But when you've got a large left to right shunt, then more blood is going through the lungs, and that's what causes pulmonary congestion. And that increased pulmonary blood flow causes, first of all, congestion of the alveoli, and then congestion of as I said, the bronchial mucosa, and then it can high blood cause pulmonary hypertension, and firstly, that's pulmonary hypertension is reactive. That is, you get in response to the high pulmonary blood flow, you get pulmonary vasoconstriction, so that puts the pulmonary vascular pressure up, the PVR, pulmonary vascular resistance up. After a while, you get remodeling of the pulmonary vasculature, intimal thickening, and that can lead to fixed pulmonary hypertension. Now, that's much less common, and it occurs in children that have much more advanced disease. And of course, that is the name of that is Eisenmenger syndrome, when you get a reversal of flow because the pulmonary hypertension is fixed, and instead of a left to right shunt, then you get a right to left shunt. Again, that's not heart failure. That's what happens if you don't correct the underlying ventricular septal defect. All right, so we talked about ventricular septal defects and the differential diagnosis, bronchiolitis, PDA, etc. Also myocarditis. This second case is a 12 or 13-month-old boy who he was exclusively breastfed, and he'd been unwell for 5 days. He had a temperature when he came in of 39 degrees. His family thought he was well up until 5 days ago, but I think even to look at him, you'd realize he wasn't well. But there are many children that have progressive, slow, severe anemia, and their families don't recognize it. But then they will typically recognize it when they have an intercurrent infection or they go into heart failure. And this boy was severely pale. You can see his hands, the palmar pallor, and he was very tachycardic, heart rate of 190. You could feel his liver 5 centimeters below the right costal margin, and he had fine inspiratory crackles throughout his lungs, especially, remember, listen posteriorly, fine crackles throughout his lungs and expiratory bronchi. Remember, listen for those, listen to know whether crackles are in inspiration or expiration, and whether the bronchi are in inspiration or expiration. And typically in heart failure, you'll hear the crackles in inspiration, fine crackles in inspiration, and bronchi in bronchi or wheeze in expiration. This was this boy's heart chest X-ray, and you can see how big his heart was, and how congested his lung fields are. This is severe heart failure, and the severe heart failure was due to this. His hemoglobin is 40, and so again, progressive anemia can lead to heart failure if it's not corrected. And I've talked about this before in a discussion about anemia, but I think there's a lot of things we can gain from just a full blood count. And I want you to be able to, we may have limited investigations available, but often we don't make the most of those that we have. And I think there's so much you can tell from this full blood count of this child. And so his hemoglobin is low. We recognize that. Remember, you look at next at the MCV, the mean cell volume, and you can see how low his MCV is, 50. And already you're starting to think these are microcytic cells. They're small cells. Remember the red cell distribution width, that's 18, so it's high. And what that means is there are populations of very small cells, and some that are a bit small and some that are normal size. So there's a wide variation of the red cell size distribution. And that's particularly characteristic of iron deficiency. It also can be seen in severe sepsis and some other conditions, but remember, you're looking at the hemoglobin first, then you're trying to see, is it normocytic or microcytic or macrocytic, right? And this is a microcytic anemia. Also, his red cell count, you look at his red cell count, RCC, that's 2.9, and that's low. In in iron deficiency, typically the blood's not making enough red cells as well as not making enough hemoglobin. Because of the lack of hemoglobin, there's not enough there's not enough hematinics to make enough red cells. This is a bit different, for example, to thalassemia, where often the red cell count will be within the normal range, maybe a bit low, but it will be within the normal range. So this is hypochromic microcytic anemia with a high red cell distribution, with this child's got severe iron deficiency. And again, it's about pattern recognition. It's consistent with this child having been exclusively breastfed to 13 months, where, as you know, breast milk provides enough iron for the first 6 months, but beyond that, it doesn't provide enough iron. Unless a child's supplemented with good complementary feeds that are iron containing, then they will become iron deficient and eventually develop anemia and then go into heart failure. Now, there's some other things you can see from this, and one is the NRBC. These are called nucleated red blood cells, and some laboratories report them as not NRBCs, but reticulocytes. And you would expect that in iron deficiency anemia, his reticulocytes would be very low, and they are 0. That is, the bone marrow is not making any red blood cells. So something that's just another feature on the full blood count that can give you a clue to what's going on. If, for example, the child had a hemolytic process where the red cells were breaking down, then his reticulocytes would often be quite high because the bone marrow is trying to produce lots of red cells, but they're being broken down in the circulation, right? So the retics would be high. The next thing you can see is his platelet count, and you can see that's high. And that again goes along with iron deficiency. Reasons that are not entirely clear to me, the platelet count is often high in children with iron deficiency. Now, remember I said this child presented with a high fever and very unwell, and it's common that families don't recognize their child going into iron deficiency or going into progressive slow anemia because they just see that they don't see that there's been an abrupt change in the child's condition. But this child, this is the full blood count of this child, and you can see something. You can see something more about the precipitating cause of this child's heart failure, and that is the white cell count was 51. The neutrophils were 18, so you think, well, it's a bit high, but it's not very high. But I want you to look at the other features, especially this thing called the band count. Now, when you're looking at the white cell differential, look for immature forms of white cells, right? And as white cells are developing, they go from the most immature forms, which are like promyelocytes, and then they go to metamyelocytes, and then they go to myelocytes, and then they go to band forms, and then they become neutrophils. And in a blood film that's got a lot of myelocytes and metamyelocytes and band forms, that means that the bone marrow is churning over a lot of white cells, trying to push out a lot of immature white cells into the circulation. And you can see that a lot of this is what's called, some labs report it as a left shift. So it's shifted to the left of all the immature forms. Instead of, you look at most full blood counts of well children or children who don't have severe infection, severe sepsis, and most of their neutrophils will be mature ones. They won't be so much the immature forms. And so this is the white cell differential of a child who's got a very large left shift, and it suggests that the child's likely to have severe bacterial sepsis, and that's what this boy had. Remember, the underlying cause of anemia is typically due to nutritional, but there are some other causes that are quite common, including iron deficiency, and including, I should say, of iron deficiency, including hookworm. Many children have hookworm infestation. This child also had severe iron deficiency, and you can see just look on the corners of his mouth, and you can see this thing called angular cheilitis. We often learn that as students, but we don't often see it. But this is the angular cheilitis of severe iron deficiency. There's almost always a precipitant, And it can become some infection that's quite trivial, like a viral infection, or it could be severe bacterial infection, severe bacterial sepsis. So that's what this child manifested. Again, you need to be able to identify the underlying cause of the heart failure, in this case, severe anemia, and the underlying precipitant for the child going into heart failure. Right. This was this child's chest X-ray, the first child's chest X-ray I showed you, and I just want you to see how to measure the size of the heart. Remember, it's the cardiothoracic ratio, and in this case, it's the largest diameter of the heart and the largest diameter of the thoracic cavity, and we get used to. We get used to more than 0.5 as being abnormal, but probably in children, especially young children, especially when they've had a supine X-ray, which most very sick children have supine X-rays, don't they? They don't have they don't have X-rays where the X-ray plate is anterior, and so the heart is a bit enlarged simply because of the direction of the beam. But a normal cardiothoracic ratio is less than 0.6, and you can see in this case it's much larger than that. Right. And the third case I wanted to mention is a little different. So we talked about ventricular septal defects and their differential diagnosis. We've talked about an older infant or a young child who presents with severe anemia and heart failure. This was a 12-year-old boy who presented with a high fever and difficulty breathing. And he'd been unwell for a couple of weeks. And he'd also noticed palpitations. That was one thing he noticed. He was quite tachycardic, and his pulse was irregular in rate and volume, irregular in rate and volume. And his apex beat was prominent and palpable in the sixth left intercostal space in the mid-axillary line. And he had crepitations in both lung fields. And you can see from this just how congested his lungs are. And perhaps you can see that he's got bilateral pleural effusions as well. And this would be the typical features of an older child who's got heart failure, also commonly seen in adults who have failure. They often have transudate in the pleural cavity and severe pulmonary congestion. And as I said, he had oxygen saturation a bit low on air, and he looked quite pale. And so the differential diagnosis of this, again, it's a bit different to younger children, but of course, rheumatic fever and rheumatic heart disease. And we see a lot of that in school age or adolescents. They may have been known to have rheumatic heart disease before, or this might be a new diagnosis. There are some other things that can cause this, including primary arrhythmias, either atrial fibrillation or supraventricular tachycardia, or another one called atrial ectopic tachycardia, where eventually, if you've got AET or SVT for long enough, then you'll go into severe heart failure. And then lastly, a 12-year-old boy who presents with heart failure without any previous diagnosis, you should think of myocarditis, particularly viral myocarditis, not so much congenital, because usually it presents earlier in infancy and young childhood, but particularly myocarditis. And we'll probably see quite a number of cases this year. It's been a bad influenza season in the northern hemisphere, so I think probably during the respiratory viral months, we'll see a lot more influenza, and there will be children who have viral myocarditis from influenza or enterovirus or Coxsackie virus. There's a lot of that going around at the moment. I just wanted to, I talked a bit about this before, but just to understand the cardiovascular pathophysiology of acute rheumatic fever, and remember it's an autoimmune disorder in some ways, triggered of course by group A streptococcal infection, by pharyngitis or pyoderma, skin infection. The antigen of group A streptococcus presents to T cells. Won't go through all the immunology, but remember, of T cells, there are T helper cells and T killer cells. Well, you get in acute rheumatic fever both T helper cell activation, CD4 cells, and B cell activation. And the B cells produce antibodies, IgM or IgG, and they're often cross-reactive antibodies, and they cross-react with lots of other tissues in the body, including the heart including the brain, including the kidneys. And in terms of the heart, they affect the cardiomyocytes, so the heart muscle cells, and also the heart valves. And that leads to the inflammation that we see on the heart valves of the vascular endothelium surrounding the heart valves. And that can lead to pericarditis or myocarditis or valvitis. And we typically see the valvitis, but don't forget these children can have pericarditis as well and myocarditis. They can have myocardial inflammation and therefore myocardial dysfunction. Eventually, you get valve fibrosis and thickening. That can occur with the first episode, but it can also be cumulative and occur more later on. And that leads to either valve stiffness and either stenosis or regurgitation, or both. You can have a stenosed valve that's also regurgitant because it doesn't close properly, but it's still too narrow for blood to easily pass through. As you know, the mitral and the aortic valve are the most commonly affected, and they typically cause left heart failure, don't they? Because of heart failure and usually stretch on the left atrium, then patients can often go into atrial fibrillation, and that can be a precipitant for a child with stable rheumatic heart disease going into heart failure. Remember, you need atrial contraction to fill a ventricle, and if you've got atrial fibrillation, then the abnormality is typically that you don't have that atrial systole, so therefore the left ventricle doesn't fill adequately. That's an important concept of what the pathophysiology of atrial fibrillation is. Of course, sometimes the heart rate can go too fast too, but it's the ventricular rate can go too fast, but it's the lack of atrial systole that is generally the biggest problem. And then sometimes you can get in rheumatic fever, you can get conduction defects. So if you get inflammation of the myocardium, then that can affect the conduction pathways, and that can lead to AF as well. It's both stretch and inflammation of the myocardium. And as you know, that other features are arthritis, and that can be antibody mediated, and also sometimes the antibodies bind to the basal ganglia, causing chorea, so Sydenham's chorea, of course. Whenever you're treating heart failure, you need to identify the underlying cause and the precipitant. We talked about the underlying causes, but when you're looking at the underlying cause, we've talked about that, but there's many different precipitants that can lead to heart failure. I'll just go through those shortly. The pharmacological treatment of heart failure, firstly, think about it as preload, afterload, and contractility. And when we give diuretics, furosemide or spironolactone, we are really reducing preload on the heart. When we're giving ACE inhibitors, enalapril or captopril, we're reducing afterload on the heart. So you're reducing the work of the heart, the work that the heart has to do. And occasionally we can give something to improve contractility. I would say digoxin has a very weak effect on cardiac contractility, and so these days we rarely give digoxin unless a child's in AF. And it's a very good treatment for atrial fibrillation. It'll slow the heart rate. It'll sometimes revert the rate from atrial fibrillation to sinus rhythm, but typically it just slows the heart rate. It's not so good for children who have other forms of heart failure. And if a child's got impaired myocardial contractility, there's some other medications that can be given. But first of all, reduce the preload, reduce the afterload, and then think about the contractility. Unless a child's got severe forward failure and they're in cardiogenic shock, then they need something to improve contractility. Sometimes using beta blockers can help as well if they've got AF they can, slowing the heart rate can improve ventricular filling and therefore improve the function of the heart. Beta blockers are worth thinking about if you've got a child who's got severe tachycardia. And then for sort of chronic heart failure management, then it's very important. Nutrition is very important in these patients, and as is exercise, actually. And of course, we look after a lot of young infants or young children with heart failure. But if you're an older child with heart failure, very important that they maintain mobility and exercise as much as they can. And our all of our treatment should be based around trying to enable their heart failure to be adequately treated, that they can still mobilize and they can still do some exertion. The precipitant is quite important. I'm going to talk about that. And especially in children with rheumatic heart disease, we often see children with RHD and we um, we just think it's another, they might have had another episode of acute rheumatic fever, but really important to identify any other precipitant. I mean, sometimes it's lack of adherence to anti-failure medication. They were on furosemide and an ACE inhibitor, and they ran out. And sometimes it's just worsening of their mitral regurg or their aortic regurg because of inadequate anti-failure treatment. They were either not put on enough in the first place, or they have gone off it. And sometimes, of course, it's an inevitable progression of their valvular heart, but 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 often there are other precipitants, and they include anemia. If a child's hemoglobin drops from 11 grams per deciliter to 7, then they will go into heart failure if they've got um, they'll go into heart failure if they've got um, uh, if they've got underlying rheumatic heart disease. So think about their hemoglobin, think about whether they're in AF or not, and think about whether they've got some other infection. Even it doesn't have to be severe sepsis. If they've got a respiratory infection, if they've got a urinary tract infection or a pneumonia, they're likely to have a deterioration. Sometimes a child will have endocarditis, so think about that because they've got underlying valvular heart disease. They might have had a bacteremia, and then they get valvular lesions, and sometimes they'll have a pericardial effusion. So just think about the precipitant of a child's heart failure. It's especially important for children who've got rheumatic heart disease, but also for children who've got some other form of heart disease. I just, at the end, lastly, I want to just say something about the monitoring of severe heart failure. And children with severe heart failure, they should be in a an ICU setting or a HDU setting within a ward. They shouldn't be down the back of the ward. I mean, so that's why I want you to try to identify those more subtle signs of heart failure, especially in older children. Don't put them down the back. They need very intense monitoring, and they need quite intense therapy. And often the standard doses of furosemide that we talk about, 0.5 mg per kilogram BD or daily, is not nearly enough for them. And at least in the first instance, they'll often need 6-hourly furosemide, 1 mg per kilogram typically, and spironolactone, 12.5 mg, or 25 in an older child for sure. They just need a bit more intensive therapy, often in the first couple of days. And it's surprising how much their heart failure can improve if you diurese them adequately, if you correct the underlying precipitant, whether it's anemia or AF, if you slow their heart rate, etc. Important, as I've said, to check their renal function. And it's very common for children who've got particularly rheumatic heart disease or myocarditis to have impaired renal function. For the reasons I mentioned, they may also have impaired liver function because they've got gut ischemia and they've got splanchnic ischemia. With nutrition, you need to be at the start quite cautious because they often have relative hypoperfusion to their gastrointestinal tract. Be cautious to start with, but then afterwards, when you've treated their heart failure adequately, they typically need increased caloric requirements. And for example, I mean, the child who's got a ventricular septal defect and is failing to thrive, the infant like that, they'll often need somewhere between 150 and 200 kilocalories per kilogram per day to maintain their growth. And that's not 150 to 200 mils per kilo per day because it'd be too large a volume. So sometimes you need to fortify their feed. They fortify their feeds so that they're getting lower volumes and higher calorie requirements. For some children who've got severe heart failure, if they've got severe forward flow heart failure, then um, let me just, yeah. If they've got forward flow heart failure, as in they've got hypotension, or on their echo, they've got poor contractility, or they've got evidence, for example, of poor kidney function or splanchnic hypoperfusion or liver failure, or, they've just got very poor myocardial function, then using low dose adrenaline or low dose dopamine can help. I prefer, these days, I use much more adrenaline. Um, and I mentioned in the talk last week about low dose adrenaline, and the doses you use somewhere between 0.05 and zero point 0.1 micrograms per kilogram per minute. And for a short term, for a relatively short term, for a day or so, not much more than that. You can give it peripherally if you've got a good peripheral line. Not all children are going to have a central line. You can give it through a peripheral line as long as you've got a good line, a nice sufficient line that's bleeding back well, and it's checked regularly. Again, these children need to be monitored in a ICU setting. But the combination of high dose furosemide, spironolactone, low dose adrenaline, correct the underlying cause, correct the precipitant, whether it's anemia or AF or infection, whatever, then that can often lead to, a substantial improvement in these patients. And, if their hemoglobin is low, a cautious blood transfusion with even more diuretics on board, that it's surprising how within 24 or 48 hours, these children can feel much, much better. Last week, I talked about the way you can make up adrenaline in to be run peripherally. I won't go through this again, but there's other ways to do it, other ways to make up adrenaline so that you can run it peripherally, including using a milligram, just one vial in a litre. The problem with that is that you have to give much larger volumes of fluid, and in children who've got heart failure, you don't want to give them large volumes of fluid. So this prescription, if you like, this recipe, is a good way to limit the amount of volume you give to a patient, but still give them the right dose of low dose adrenaline. So in these prescriptions, on average, we're giving 0.04 to 0.05 micrograms per kilogram per minute, which is a good start for patients who've got heart failure, just to give them a bit of increased contractility, I think. And that will often improve their blood pressure a bit. It'll improve their cardiac function. It improves their renal blood flow. It improves their splanchnic blood flow. Don't use much higher doses of adrenaline. This is very important because there's this concept of a metabolic cost of using catecholamines, and that metabolic cost means that when you're giving adrenaline, then when you're giving adrenaline to patients who've got heart failure, you're driving the heart a little bit more. It might not go much faster, but you're increasing the metabolic work the heart has to do. And so there is a threshold above which, if you give too high doses, all you'll do is cause the heart to require more oxygen to pump adequately. And so low dose is fine. Higher doses I'm wary of. And so much higher than 0.1 or 0.15 micrograms per kilogram per minute. And then you're really causing the heart often to do more work. Sometimes we have to in the early stages, but usually this low dose adrenaline will be quite good. But again, as long as you're giving adequate diuresis, you're correcting the precipitating causes, be it anemia or be it AF or infection, sepsis, whatever. Yeah. So we've talked about today just 3 cases of heart failure, and I've just illustrated that the causes and the differential diagnosis are different at different ages with different presentations. And again, I said most of pediatrics is about pattern recognition. And so the first child was a large left to right shunt. It was a ventricular septal defect with a differential diagnosis of bronchiolitis or a PDA. The second child had a nutritional cause of heart failure, which was severe anemia, and a precipitating cause of severe sepsis. And the third child was a child who had rheumatic heart disease, a 12-year-old. But remember the differential diagnosis, severe viral myocarditis or a primary arrhythmia and identify which one of those it is. You should think of the differential diagnosis at each age and look for and treat the precipitant and then of course treat the heart failure. And I think treat it aggressively in the first 24 or 48 hours if a child's got severe heart failure. And that includes, all the things we've talked about in terms of the care of the critically ill patient. And often you find that their heart failure improves a lot and they get back to ambulating, mobilizing, to eating again, and feel much better generally in themselves. So that's all I wanted to say today about heart failure. You could, if you wanted to, have a look at the lectures I've given on congenital heart disease and other forms of structural heart disease. I think that they're sort of complementary. So I want to say today to answer any questions that you might have, if you've got any. It looks like I'm going to stop the recording now.